Hello, everybody. I'm Maurizio Scarpa, and I welcome you to the third webinar of this series. As you know, in the previous two webinars, Professor Paul Armatz and Dr. Cristina Lampe were making a very good and very outstanding webinars regarding mucopolysaccharidosis of different aspects. And tonight I will speak about mucopolysaccharidosis, but in a different way, how to understand why the mucopolysaccharidosis have so many different symptoms, signs, and phenotypes. I am Italian. I work at the Regional Coordinating Center for Rare Diseases at the University Hospital in Udine, which is a northeast city in Italy. And what I would like to remember you is actually this very simple housekeeping note. Do not take any screenshot, please. Do not reproduce slides. We will have about 30-35 minutes of talking. And the important thing is the questions that you are very welcome to do. And you can actually put your question in the chat panel. At the end of this webinar, I will read and answer directly to you. A recorded webinar will be available at this website after my talk. So these are my disclosures. As you see, I work with quite a lot of different companies. But I don't have any interest in the market of this, and all the presentations and the pictures are with permission. So let's start with the first part of my talk regarding a summary of what it is a rare disease. I think that not all of you have followed probably the two previous webinars, so it's better to have a summary. What is a rare disease? A rare disease is a life-threatening chronic disease. We count about 6,000 to 8,000 distinct rare diseases according to different classification, but about 250 new described disorders are per year described in the literature. The definition is for a rare disease is to affect less than 5 people every 10,000 citizens. And globally, let's say that from 6 to 10% of the global population is affected, and in Europe is about 30 million people. 80% of these disorders are inherited as a genetic mutation. 70% of them affect the neurological system. 50% of the rare diseases affect children, and 35 of these children do not live more than 1 year, and 30% of the children do not live more than 5 years after birthday. The most important thing is also that most of these diseases cannot be treated because 95% of them do not have approved drug treatment, and for this it is important to work on the search for orphan drugs. Let's say that the definition of an orphan disease is a disorder which has not been adopted by pharmaceutical industry to provide a therapy because of lack of interest in the market and little financial incentives. And for this, the term that is being used is orphan because nobody is thinking to them. So there is no actually satisfaction in definition on orphan disease because it is not really this kind of definition that is presenting the entire meaning of this disorder. In the different continents, you see that the description of why we call a disease a rare disease is different. For example, in the USA, you have a disease with less than 200,000 patients. In the EU, as I said, less than 5 per 10,000, and in Japan and in Australia. But you see that more or less they are very similar. The fact that you are affected by rare diseases is really an odyssey for the patient. You have to remember that most, if not all of these disorders do not have specific signs and symptoms. So the patients and the family can go around looking for a diagnosis for years. It has been said that an average from 5 to 7 years is spent from the patient to have a diagnosis. Sometimes you have 2 to 3 different diagnoses from the real one, and this means also to receive wrong therapies that sometimes are really harming the patient. Let's say that, you know, if you want to understand what rare disease and how frequent diseases are, if you are in a full booked bus, let's say that 4 people might be affected by rare disease. If you go on a crowd elevator, let's say that 1 person can be affected in the life by a rare disease. So you see that rare diseases are everywhere, and really they are rare altogether. They are rare singularly, but altogether they are not so rare. Rare diseases can be misled, misdiagnosed, as I said. This is the example of a child who is a nice child at the age of 3, but the family was already seeing that this child had some rigidity in the major joints. When she was an adolescent, you see that she had this kind of rigidity and pain in the skeletal joint, and she was diagnosed with rheumatoid arthritis, and she went through a lot of usual cortisone and anti-inflammatory treatment without any benefit until she was 50, and she got the diagnosis of mucopolysaccharidosis type 1, and then she received the enzyme, and but it was of course too late. So this lady was indeed suffering for more than 50 years and being treated for a different disorder before having the right diagnosis. This is the example of another man. As a child, you see that this child have an abdomen with an umbilical hernia. He is older than the sister, and you see how short he is. And then even if he's older growing, he is always shorter, and really with a short neck and a large thorax. You see that also here you have rigidity in the joint, and also him, after a long time of being diagnosed with a skeletal dysplasia, and even here with a rheumatological disorder, he received the MPS 1 diagnosis as well over 45 years of age. As you heard in the previous webinar, the mucopolysaccharidosis are actually 7 diseases caused by 11 the effect of 11 different enzymes. You see here in red the disorders which have now a therapy, and you see that beside having a single enzyme, the disorders are due to the accumulation of termatane reparan sulfate or keratan sulfate in the case of MPS 4. This accumulation is present in all the centers. They are lysosomal disorders, and as you know, lysosomes are in all the cells of the body beside the red blood cells. So I mean, all the cells of the body are affected by the storage. Indeed, for this case, the accumulation is affecting all the different organs, the CNS with mental retardation, and we will see some, then deafness, corneal clouding, and then the skeleton, rather the ENT, the lung, the heart, and the abdomen, and 70 to 80% of them involve the central nervous system. If you know the disorder, is very easy to diagnose, because I mean, you can take just a drop of urine, and the disease itself is just easy to diagnose, because with the concentration of the dermatane and the parasulfate, you can even start thinking when you have a urine analysis. So if you really know this disorder, you can suspect by the phenotype, and you make in a few hours the right diagnosis. These diseases, as you saw from the previous webinar, share and have commonalities in features. You see here a panel in which you see that there are different features like the intelligence, the behavior, the coarse facial features, the cardiac problem, the short stature that can be present at different levels, but more or less they are present in all the different MPSs. As a matter of fact, indeed, if you group all the patients affected by the different type and subtype of these diseases, you see that they can all come from the same family because they have all of them, beside the different enzyme deficiency, very similar features in terms of skeletal, in terms of abdomen, in terms of facial features, with a different grade of CNS involvement, like in the MPS 1 Harler, in the MPS 2 type A, in the MPS 3 Sanfilippo disease, and in MPS 7. However, inside even the same disorder, you can have different spectrum of disease severity. This is, for example, the MPS 2, the Hunter syndrome, in which patients having a similar enzyme level and genetic disorder may have a different spectrum for a very severe and neuronopathic phenotype to, let's say, attenuated and non-neuronopathic, so with a full alteration of somatic and central problems to just somatic and totally spared CNS activity. So, I mean, this is very typical of this disorder. And so, I mean, it is very difficult, you know, to understand exactly which kind of spectrum the child might have just at birth and with a genetic and lysis and enzyme level. You can also have the distinction of this disorder in the stiff ones and the hypermobile. Usually the MPSs are having all joint stiffness beside one, which is the MPS 4 type A and B, because I mean this disease is actually very much affecting the skeleton, but the joints are much softer than in the other kind of disorder. The only disease which is affecting the CNS in all the different type is the Sanfilippo. We have 4 kinds of Sanfilippo diseases due to 4 different enzymes, but all of them have a very severe CNS involvement. The clinical course of this disorder in the severe phenotype is very important, because the facial dysmorphia, the corneal claudia, and the cardia, the musculoskeletal, the episplenemegaly are affected in the first decade of life, and the life expectancy is at the maximum of the second decade. In the slowly progressing MPSs, the same features are much slower in progression. The life expectancy is reaching adulthood up to 60 to 70 years of age. Of course, these are so-called more attenuated phenotype, but of course, to live also with this disorder is not easy, due to the fact that this progression is in any case altering the quality of life of these patients. Just very quickly to remind what already has been said by Christina and Paul regarding the typical joint stiffness of the skeleton, and so the claw hands, which is really a typical sign of the MPSs, together with the tiptoes walking and the rigidity of the joint. I remember you that the joint stiffness is also followed by an alteration of the spine with scoliosis, with the flattening of the symphotic, and then a lordosis, which is very very accentuated, and then here you have problems of the hips that can bring the patient to have a prosthesis and a hip replacement. One distinctive sign that you need to be very careful is actually a lordosis, a syphotic lordosis, which is present in the lumbar part of the spine. You see here, due to the alteration of the genesis of the vertebral bodies with big scoliosis and hip dysplasia. The accumulation can also affect soft tissues, like, for example, the larynx, and this is the feature of the larynx with a lot of gag, and also in the ear you see how infiltrated can be the middle and the inner part of the ear. You can have also accumulation of gags in the cornea, which is very typical of the MPSs and very minimal in MPS 2. And this feature, especially in the MPS larynx accumulation, it's a nightmare for anesthesiologist, and is really a risk, you know, for any kind of anesthesia that the child can require, even for minimal surgery procedure or even for an MRI. The cardiac signs and symptoms is very common in this disorder, and with specifically a valve disease, which is present mostly in the mitral, aortic, tricuspid, and pulmonary valves in this exact level. So the first valve which is affected is the mitralic valve, and then you have the other two. This kind of alteration can give to pulmonary hypertension and hypertrophy, by ventricular hypertrophy with cardiomyopathy, and you can have patients affected by arrhythmias and abnormalities of conduction, which can be sometimes fatal, and also giving a congestive heart failure in the very late stage. At the central neurological problem, you have a very typical cervical stenosis, which is also giving a peripheral neurological sign very important to the patient, and then different levels of enlargement of the ventricles with enlargement of the Virchow-Robin system. And also the carpal tunnel is very frequent in these children. Remember that carpal tunnel is not a pediatric disease, and if you have a carpal tunnel in a child, the first thing that must be done is to rule out a lysosomal disease. Okay, so I was going through very quickly with the most important signs and symptoms of this disorder, but do we know why these children have this kind of signs and symptoms? Let's say that these are lysosomal diseases, so they are storage diseases. You know that these disorders are due to a genetic defect of lysosomal genes. So you have a defect of a protein which is degrading the glycosaminoglycans, and the glycosaminoglycans are stored in the lysosome in the cell. So in the 1976, Bob Dexnate was saying that these metabolic disorders were the simplest metabolic disorder, because it was they were done by one gene defect, one protein defect, one compound which is stored in the body, and for this the accumulation of the stored material in the lysosome was giving apoptosis to the cell, and for this reason the cell was dying. So very simple, everything is due to the stored material. But if you see, for example, the different organs, you see that indeed in the liver you can even stain very nicely the GAG storage, and you can see even with a low magnification. In the spleen you can see the stored material in the tissue, but if you go to the brain, actually, which is very much affected in 70% of these patients, you don't see very much deposition of glycosaminoglycan. And actually, you don't think that with such a deposition, you can have such a severe CNS disorder. So after this description, the idea that the store material is the unique responsible for such a terrible disorder start to be not so sure anymore. Up to, let's say, the 80s, 90s, the lysosome was supposed to be just a garbage tank. All the material that need to be recycled or destroyed go directly to the lysosome, where there are about 100 enzymes. Each enzyme are working like in an industrial chain, so they are degrading the different molecules in monomers, and that's it. This was indeed the idea that the lysosome was the end part of the metabolic pathway of a molecule. But in the middle 90s, what has been shown is that the lysosome was in strict contact with a lot of other pathways in the cell, with endocytosis, with, for example, chaperone-mediated autophagy, with ubiquity in proteasomal system, with microautophagy, with mitochondria, with the Golgi, even with the nucleus. So at a certain point, the lysosome, it was not considered anymore just a garbage tank, but a central part of metabolism and the welfare of the cell. So what I will do here is to go very quickly through these 5 points, that the lysosomal storage is not an homogeneous process, that you might have a problem due to lysosomal problems due to the endocytic events, that there is also alteration of other systems like calcium homeostasis, endoplasmic reticulum stress, and other part, that the lysosomal disorder were also very important to rediscover the autophagic system, and that it is a problem of recycling, which is important for lysosomal disorder. Let's say, for example, that in the lysosome, you don't have only material that is recycled due to just endocytosis, but you can have, especially in the neurological system, alteration of the endocytic trafficking. And so for this reason, the alteration of the lysosome can have a result in the entire architectural structure of the brain and the brain tissue. And this is particularly true because if you make a biopsy in the brain of this patient, you see that the neurons have actually this kind of very strange phenotype with ectopic dendrites and creation of new synapses. And if you go and make a detailed analysis of one of these ectopic dendrites, you see that there are some spheroid neuroaxon which are totally dystrophic, with a lot of bodies that are actually causing the death of the cell. And if you see also the flow of the axonal transport of the different materials inside the neurons, you see that there is an alteration of what is the normal transport. So the entire activity of this cell, not only the accumulation of the lysosome, is affected by a lysosomal storage. And this is present in all the different neurological cells, in the Purkinje, in the basal ganglia, in the non-pyramidal cell or the cellular cortex. So the alteration of this storage is really generalized. Another important thing is that the engulfment of the lysosome with store material does have some important effect, not only inside the lysosome, but also in other metabolic pathways. And this is present not only in the MPSs, but also in Gaucher, in the Niemann-Pick, in the GM1 gangliosidosis, in Niemann-Pick-C, and in the infantile NCS. And this is because there is a sort of communication between the lysosome and a lot of other systems that are present in the different membranes, like the ryanodine receptor, rather than the the calcium depletion due to alteration of the calcium receptor and channels. It is also important to remember that also cholesterol is affected inside this cell, affected by a stored material in the lysosome. So the primum movens is indeed the stored material, but that the alteration of the lysosome is causing also alteration of other systems in the cell. Let's say that this is also important to understand, because since we have calcium alteration, we can use some calcium blocker as therapy. Since we have endothelial ER stress, so the endothelial reticulum stress, we can have also some blockers working. We have calcium modulators. We can even have other cholesterol therapy that can be done. And of course, this kind of knowledge can really start understanding about the cell death, which is a very complex pathway, and not only the alteration due to the stored material. So at a certain point, what it is also important is that there is a system which is the autophagy, which is very important in our cells, because we are producing continuously material that are not usable in the metabolic system, and these are labeled and then they are destroyed. But it has been seen that in the lysosomal diseases, the fact that there is an accumulation in the lysosome is altering also the autophagy. So at a certain point in all the different diseases, and the MPS is rather than other lysosomal disorder, what has been seen is that the material that need to be destroyed are not properly recognized. So the ubiquitin part is really not working very well. So there is not only the stored material due to the original enzyme defect, but there is also an accumulation of a lot of other material that should be cleared up by the autophagic system, but it is not, because the autophagosome and the lysosome are not collaborating in this system. And this is also important, because it is giving the start to inflammation, especially in the CNS. Here in this very nice paper, what it is very nice is to see that after the original stored material, there is an increasing amount of inflammatory molecules that are causing inflammation in the brain and degradation and neurodegeneration of the cell. For this reason, for example, what has been seen is that in the different brain tissue, you can have not only glycosaminoglycan storage, but even amyloid are stored for the reason that I just said. So amyloid can be found, you can find even synuclein, which is typical of the Parkinson disorder, and you can find even a prion protein, which is not, of course, a glycosaminoglycan, but you can be found in the brain of MPS animal models. The nice thing is that whenever you are able to put inside the enzyme, or to produce, to express the enzyme which is missing, also this material is cleared. So these are further aggregation, further storage, which are the effect of a secondary cascade of events following the original gene defect and the original GAG accumulation. So, the proposed model is that it is indeed the lysosomal enzyme a sort of easy disease, because it is due to an enzyme deficiency. There is indeed a lysosomal storage disorder, but this is not enough. The lysosomal storage is indeed increasing an impairment of autophagy. The impairment of autophagy is responsible for accumulation of toxin proteins, and then there is an alteration of important organelles like mitochondria. So there is also an energy depletion in the disease. At a certain point, all these process result in a cellular distress, particularly in the CNS, phagocytosis by microglia and activation of microglia, a chronic inflammation with a release of cytokine, and after all this cascade, of course, the cell at a certain point goes in apoptosis because of different toxic effect. This is something that is extremely important because also for therapy reason, at a certain point, what we want is not just to give the missing enzyme, but we need also to understand how to intervene to correct also other aspects like inflammation in this disorder when the patient has already a diagnosis and is not treated asymptomatically. This is what you have seen important for the brain, but you see here that there is another organ which is very much commonly affected by these diseases, which is the skeleton. And for example, in this disorder, which is the mucopolysaccharidosis type 4, the Morchio, you see that even here there are different grades of severity, and the skeleton is very much involved. And this is the only disease which is totally sparing the CNS. So these are perfectly normally and intellectually normally children with different severe skeletal deformities. And this is the typical signs. And if you remember, this is the disorder which is not having a joint stiffness, but actually an hypermobility and laxity of joints. The disorder is distributed, as you see, in all the different parts from the small bones to the larger bones. So it is responsible as for a dysostosis multiplex. The defect is always the same. Even in the chondrocyte, there is an enlargement and engulfment of the lysosome, which is giving the destruction of a normal architecture of the bone. And you see here that there are different grades of scoliosis and alteration of the bodies as a result of this alteration. But if you see what is causing, and you go and see some biopsy of these bones, you see that there is an infiltration of inflammatory cells, like here a lot of lymphocytes. You can recognize macrophages, which are containing quite a lot of engulfed lysosome. And if you see even what is present in terms of molecules that are released in these joints, you see that there is an incredible amount of inflammatory genes that are altered and producing inflammatory molecules that are responsible for the alteration of these bones. And as a matter of fact, very nice work by Lili Simonaro was defining that the entire TGF beta structure is altered. The TGF beta is a sort of orchestral director of a lot of inflammatory molecules, and with the alteration of TGF beta, which is very much present in this disorder, as a consequence, there is also an alteration of all the molecules that the TGF beta is controlling. And also this is a secondary cascade of events which is leading to the alteration of the skeleton. What is the result? The result is that if you want to have a very normal bone developing in the normal, you have to have during the growth of the patient a very balanced expression of different molecules that are regulating the bone growth. In the case of, and this is of course resulting in a very regular, anatomically regular distribution of the different cells from the reserve zone to the metaphysis. So with a lot of regular cells that are distributing in columns and are differentiating to the metaphysis. In the case of the MPSs, what you see is that the dysostosis is an abnormal and irregular formation of this architectural structure, and for this reason the bones are not developing in a normal way. You see here a difference between a normal bone and an MPS 6 bone. So this kind of structure, of course, is responsible for all the alteration that we have seen in the skeleton of these patients. So in conclusion, what we can say? We can say that the mucopolysaccharidosis are really genetic, they are chronic, they are heterogeneous. You see here quite a lot of patients that Christina and myself were following when we were working in Germany together. And these are multisystemic and life-threatening diseases. Of course, they are progressive, and you see here the different cases of this lady that I explained a little bit before, and you see how these disorders are progressing and how a patient is really having different alteration over time. Of course, all of these alterations are not due only to the glycosaminoglycan storage, but the glycosaminoglycan storage is just the primum movens of this disorder, and then there is a more complex cascade of events causing inflammation, release of molecules, mediators, able to alter the physiology of the body organs at the various degree. Of course, all of these alterations are responsible for what we have seen, major clinical manifestations that are affecting all the different organs in the body, even the teeth. And what it is important is to try to recognize this disorder as soon as possible, because what I showed you is a complex system that is starting with the stored material. But if we recognize this material through newborn screening or early diagnosis, clinical diagnosis, we can really stop this progression, because it is not something that is developing in few hours. It takes years. So the important thing is to recognize this disorder, to make an early diagnosis. If they have therapy, to initiate the therapy as soon as possible, so that we can intervene, at least giving the enzyme they are missing, to stop, to modify, to alter, to freeze or to delay the complex alteration that I showed you for the CNS and the skeleton. What it is important for these disorders is that we need a team to work. We need a team of different specialists that cannot work alone. They need to work together, because these patients need to be followed with or without therapy from a lot of specialists, because they require to be seen at 360 degrees. So one important thing is, whenever these patients are diagnosed or are suspected, also all the other different colleagues can be involved and must be involved in their treatment, because at any age, at any time, you need really to follow and to manage these patients as a whole system, not only at the level of the different organs. And with this, I thank you, and I'm ready to see whether there are some questions in the chat. So let's see whether there are some chat here. At the moment, I don't see. Okay, so there is one question, which is, so skeletal dysplasia with stiffness is common in all the MPS types apart from MPS 4, where laxity is the sign. What other main sign on MPS 4 alerts you instead of stiffness? Well, this is a very nice question. The MPS 4 is a typical skeletal disorder. So differently from the other MPSs, you don't have hepatosplenomegaly, very, very minor hepatosplenomegaly. You don't have cornea cloudy cornea, or you don't have a neurological problem. So indeed, the skeletal problem is the key point of the MPS 4. So whenever you see a child with some alteration of the bones in the first year of age, with a little bit of scoliosis, with a genus valgum, which is, present together with some laxity of the joint, you have to rule out absolutely the MPS. Really to concentrate on the question of the skeleton. Then there is another question regarding how common is recurrent upper respiratory tract infection in MPS, more so in MPS 1 and 2, or are equal sign in all types? Thank you very much. I was not touching this kind of aspects because the previous two webinars were very well designing this. Nevertheless, yes, the glycosaminoglycans are like a sponge. The accumulation of these glycosaminoglycans are altering the physiology of the soft tissues for all the different MPSs. And for this reason, especially in the upper airways, you have infiltration of the soft tissues, and so you have alteration of the fluid of the upper way. So one of the first sign, together with some skeletal disorder, as we said for the MPS 4, is indeed a very frequent upper airways infections. Sometimes these children have a continuous and chronic alteration of the upper airways. And I showed you how badly is the ENT situation with a lot of hypertrophy of the adenoids and the tonsil, which require surgery very early in life of these children. And for this reason, children with recurrent airways infection, with airways infection that are not even seasonal, or they are not treatable with normal treatments, and possibly coupled with a hernia, umbilical or inguinal hernia, which are not resolving the first year of age, they are quite at risk to have MPSs. So these two signs, the recurrent infection and hernias, might lead to a suspect of MPSs. There is another nice question. Can we have vertebral anomalies, fish mouth or bullet finger in some types in 100% of cases, and when we label as vertebral anomaly fish mouth? Well, this is really a question. I mean, this is really a sign that you can see, particularly in MPS 4. You can have alteration of the vertebral bodies in all the MPSs, but of course not in attenuated phenotypes, at least up to a certain age. If we concentrate in the first year of age, these kind of signs can be seen in MPS 1, MPS 2, particularly in MPS 4 and MPS 6. In MPS 3, a little bit less, because I mean the MPS 3, all the 4 phenotypes have minor skeletal problems. But in MPS 1 Harler, MPS 2 in the neuronopathic, and MPS 4 and MPS 6, for sure these kind of problems can be seen. Remember that all the children affected by skeletal abnormalities have ekyphosis in the lumbar space, And the kyphosis, the lumbar kyphosis, is really, you know, a sign that should ask for a lysosomal or an MPS suspect. There is another nice question. In MPS 10th, there is GAGs can be normal. Thank you for this question. As a matter of fact, GAG are usually accumulated in the urine. Indeed, in the MPS 10, you can have a normality of GAG, but you can have also normality in other MPSs. Because indeed, the GAG are not always present in the urine of these children. In particular, if you have a very, let's say, attenuated form of this disease, or whether you are in the adolescent age. As a matter of fact, the concentration of GAGs decrease with the age. And even if the patient might have had an abnormal accumulation of glycosaminoglycan during the infancy, in the adulthood period, the GAG can decrease. So one advice is if you have a suspect that something can be similar to an MPS, don't give up because the GAG are abnormal, but go to the enzyme and to the genetic analysis, because sometimes you can be surprised to have GAG normality and a diagnosis of a mucopolysaccharidosis. Is early psychomotor development normal in MPS patients? Thank you very much for this. MPS 1 is divided in three phenotypes: MPS 1 Hurler, MPS 1 Hurler-Shy, MPS 1 Shy. Let's say that the most severe, the neuronopathic one, is for sure the MPS 1 Hurler. Then you have a non-neuronopathic, but with a different severe involvement of the skeleton and the organs in the MPS 1 Hurler-Shy, and a very minor somatic and absolutely normality of the CNS in the Shy. So let's say that if you have an MPS 1 Hurler, you can have even the very first months of life a psychomotor development normal. But then you have in the second part of the first year or during the first 18 months, you start having a neurodegeneration. So all these children in the very first months can develop normally, but inside the first year, you might see, let's say from the 6th month to the 9th month, some lack of achievement of pediatric milestones, or even a loss of what has been gained after the first year of age. So as an answer, yes, the psychomotor development may be normal in the very first months of life, but then if it is a severe disorder, you can have a degeneration very quickly. This is why in this kind of disease, the MPS 1, it is extremely important to understand which kind of disease you are facing, because if you make the hematopoietic stem cell transplantation in the first year of life, you can really alter the neurodegeneration, and you can modify the history of neurological development in these children. Another nice question is newborn screening for MPS on the horizon and the timeline? Thank you very much. The newborn screening for this disorder is something that is becoming more and more closer. there are already different pilot testing in different countries. Taiwan was the first country with a very big screening, and now they are screening MPS in Taiwan, MPS 1 and MPS 2, and also MPS 6. There are other countries in Austria. In 2012, there was a first pilot program on MPS 1. And now in Italy, we are doing in my center a pilot program for MPS 1 and other lysosomal disorder, Fabry, Pompe, and Gaucher, and ASMD. In the US now there is MPS 1 and MPS 2 that are routinely done in a lot of states. So I think that it is a matter of a few years to have really a newborn screening for MPSs. What it is important is not only to make a newborn screening as a newborn screening. The newborn screening is not a test only. The newborn screening is a system. You need to identify the patient, but you need also to make a prognosis. You need also to understand what to do with the therapy. So what it is important in the pilot programs is not only whether you are able to identify a defect in the enzyme level, but what kind of phenotype you can make as a prognosis. Because sometimes with the newborn screening, you are not able to understand whether the disease will be severe or not. And so I think that what it is important is to really make all this pilot testing and to understand, to make some flowcharts that could really navigate the physician in understanding what is the prognosis in order to choose the right therapy for these children. Oh, we have another question. In resource limiting setting, we usually go for urinary gags. What do you recommend? As you said, it can be normal. If high index of suspicion, if it's negative, and can we request for a specific enzyme? Well, yes. I mean, it really depends from where you are writing from. Let's say that now the quickest way is to make a urinary gag analysis, but now more and more we can make at least a screening or a few drops of blood for a lot of different enzymes, even in multiplex. So in my lab, for example, but not only my lab, from the same spot, we can do different analyses at once, and to have with a very limited cost. Then, whenever you have done this analysis, this enzymatic analysis, you can go on the genetic analysis to try to understand if there is a sort of prognosis or not, and also to help the family with genetic counseling. So I think that the combination of urinary gag and enzymatic analysis in MPS is mandatory, at least this. And then whenever you have a suspect, you can go directly to the genetic analysis. Now there are also cheap testing with panels of hundreds of different mutations and genes for lysosomal disorders. So there are panels of NGSs for lysosomal diseases. Also, these are very useful, but I think that the best test at the moment to start the diagnosis is indeed GAG and enzymatic assay. Okay, I think that we don't have questions anymore, and I thank very much for these questions because they were very much complementary my talk. So I would like to thank you for having participating to this webinar. I want to remind you that in 1 week time you will have an outstanding presenter, which is Roberto Giuliani. Roberto Giuliani is from Brazil. He's one of the major experts worldwide in lysosomal disorders. He's a geneticist from Porto Alegre in Brazil with a huge center and an incredible experience in patients, and he will close this series of webinars. So please try to be on the 20th of April at 6 p.m. Central Europe summertime to complete this webinar and also to hear what Roberto Giuliani will tell, which will be for sure very interesting and outstandingly talk. So thank you very much. Happy Easter, and looking forward to meeting you next week with Roberto Giuliani.